and bringing clarity. Over to you, Govind.
Hello. Good afternoon, everyone. It's lovely seeing all of you out here today. Building Arogya Arohan, which is an app for screening oral cancer in India. So India is the cancer capital of the world, and oral cancer is one of the largest contributors to our cancer workload. Every year, about 140,000 new cases are registered, and it causes death in 80,000 patients. And the worst part about all of this is, if these patients are screened early, our health system can provide them with good quality of life for many years to come. This is where Arogya RON comes in. Arogya RON is an offline-first AI-powered application that empowers our frontline workers, the ASHAs and the nurses, to screen for oral cancer using the cameras in the mobile phones. This talk is going to be about the challenges that we have faced and the solutions that have worked for us. So the number one challenge that we have faced is working with overworked users. On a typical day, a nurse can see upwards of 100 patients. This leaves her with less than 2 minutes to screen, record, and counsel a patient. And she's doing this across 16 different health programs. Each of these health programs have their own apps, which have been mandated for her to use by her supervisors. And these apps are not designed with the user in mind. They can be slow, clunky, ask for too much information, and have confusing flows. And to make matters worse, the nurse has to enter all of this information again into a physical register. If the app that we built was not efficient or less confusing, the user is not going to use our app and the tech will fail the program. To solve for this, what we had to do was a lot of user research. As with any complex system, you have misaligned incentives. And here, the misaligned incentives were that the requirements come from public health experts, policymakers, and doctors, whereas our real users are the frontline workers, the nurses and the ASHAs. To understand this, our tech teams and the product teams, we travel to the field and understand the entire workday of a user, not just how they interact with our app, but how they interact with all the other apps, what their day-to-day looks like, what is the kind of influence they have in their communities. And we had to understand this so that we can build an app for the user. And our goal has been to build an app that can quickly get out of the way of the user. To do this, we had to make sure that we are measuring and optimizing for the right things, not just API latencies or rendering times. They are important, but for us, we focused to measure things like what is the end-to-end time that a nurse takes to screen and counsel the patient. And this is important because you cannot optimize what you don't measure. The second challenge has been working in poor network connectivity areas. Our typical frontline workers are working in rural fields. Network is patchy, connections are slow, and like the user does not have any patience for dealing with the server downtime. We had to make sure that the app works every single time, and our benchmarks have been WhatsApp and paper because that's what our users are most comfortable with. And to achieve this, we had to make sure that our app works offline first, and that has been one of the core architectural principles in building our application. With this, we unlock two things. One, since we don't have to rely on the network, like we don't have to worry about like network not being available all the time. And the second thing is, because we've removed all blocking API calls from the core path of the application, uh, we are never like blocking the user, and we get out of the way of the user as quickly as possible. Oh, sorry. The third problem has been working in an overloaded system. So a public health system anywhere in the world is stretched thin in all directions in terms of money, money, equipment, medicines, and expertise, and especially in terms of expertise. You can't have like doctors traveling to every field and screening the patients. So we had to design the application that accounts for this. To solve for this, first we tried a telespecialist model, but that made things worse because now the user has to both screen the patient and then follow up with the patient later. So instead of like reducing their workload, we ended up doubling it. So to solve for that problem, we decided to build a custom AI model that sits on the device and works offline. With this model, the nurse can basically take images of the oral cavity of a patient and immediately know whether the patient is suspicious or non-suspicious and counsel them then and there. And in fact, because the app shows the flagged images, the nurses use this as a tool, as an effective form of counseling to improve the rates of patients going and getting biopsies afterwards. And the fourth challenge that we faced was dealing with search. In India, first names, last names are very common. Each name can have many different kinds of spellings. Phone numbers are not ubiquitous, and there's no universal ID that we could use. We didn't want to build an ID of our own because that just leads to an N+1 ID problem. So to solve this, we took sort of a counterintuitive approach of assuming that the IDs are not unique in the system. And with this assumption, basically the system assumes that the IDs are not unique, and whenever a nurse searches for an ID, they may see more than one patient, and we rely on the nurse or the ASHA worker to disambiguate between which is the correct patient, and this has been working very well for us. In fact, like we even don't call them IDs, we call them reference numbers. Okay. Finally, I would like to get to what opportunities do we have as tech and product teams in this system. When you're working in the public health system, you're interacting and collaborating with policymakers, public health experts, doctors, nurses, and ASHAs. And as I said earlier, in a complex system, you have lots of misaligned problems. This is where there's an opportunity for tech and product teams to come and act as a bridge and solve these problems in a unique way, unique and novel way. Yeah, so basically, this is an opportunity for us to take the lessons that we've learned in the industry, things like user research, fast iteration, and bring it to a system that has historically not had access to these things. It's not just about building software for like a public good or to have an impact, but it is also about tech advocacy and bringing the lessons that we have learned into the system. I would like to end with tech is not the most important part of a public health system. It's the ASHAs, the nurses, and the doctors. But if the tech doesn't work, then we don't enable our users to scale the good that they can do. If you want to get started, this is like a list of resources you can look at. And if you want more information, we can discuss after this talk. Yeah. Finally, three main takeaways I would say from this talk are know your users, assume that there won't be any network connectivity, and ensure that you're measuring what is the most important thing. I think that's it from me.